Thank you for joining this morning. My name is Sarah Wright. I'm lucky enough to be facilitating this session this morning. Our first speaker hasn't been able to join yet, so we're going to jump through to Jacinta Winderlich, who's going to be speaking on, as a dietitian from Australia, going to be speaking on the practical considerations of optimisation of nutritional provision in the PICU. Over to you, Jacinta.
Thanks for including me in this webinar today. I had a wonderful time and lots of great learnings in Mexico back in June, and I'm pleased to join and discuss nutrition in the PICU and also to hear the other great presenters today and in the second webinar of the series. So unfortunately, I don't have any financial disclosures, and I don't believe I have any conflicts of interest. I will apologise in advance. I've come into the hospital because my home internet's a bit dodgy, so apologies in advance if there's any overhead announcements. I may turn off my speaker for that time. I would also like to acknowledge and put into context, I'm fortunate to work in a well-resourced PICU that, and I guess that they're similar in my region in Australia and New Zealand, and also acknowledge that the dietitian has a relatively significant role in nutrition management. That's not necessarily always the case everywhere, but I hope that the principles we're discussing today are relevant to all PICUs. Also, to provide some context and background, I'm sure we're all in agreement that nutrition is an important consideration when we're looking at the care of the children in the PICU. This is because we know that suboptimal nutrition is associated with poor outcomes, which include reduced muscle strength, reduced wound healing, increased duration of mechanical ventilation, and duration of admission. So today, in our brief session, I would like to cover what are some of the practical aspects to consider in the optimisation of nutrition provision in the PICU. So you could speak for a whole day on this, I'd like to think, especially someone passionate like myself about this area, but I've sort of touched on about 10 of what I think are the main areas just to provide some brief reflections and some of the key resources. And speaking of key resources, it's really important if you're only going to be across a few articles to be aware of the published recommendations. So this includes the Asia Pacific, the Aspen, ESPNIC, and also ESPGHAN guidelines. So these are all excellent in providing a summary of recommended practice based on the current evidence. And I believe the Aspen document is under review at the moment. So another good starting point, I believe, is reflecting on the importance of multidisciplinary care when it comes to nutrition provision. This is probably fair to say relevant for all areas of care, but it's certainly the case for nutrition. So all team members in the unit may have a direct or indirect influence on providing optimal nutrition,
Attention, please.
whether that's,
For adults,
sorry, I'll just pause this for a moment. Sorry, this is really providing the true hospital experience with overheads. So everyone has a role to play in whether the provision of nutrition, so whether that's the nurse that's consistently by the bedside to assist with feeding or tinkering with the enteral feeding regime, medical in their role in making decisions about nutrition provision, the dietitian, the speech pathologist, the ward, PSA or AHA, which may be helping with orders. And so, yeah, I think that's an important thing to keep in mind in the background. So nutrition screening tools, I think, is an important topic to consider in all clinical areas. So formal nutrition screening tools allow for identifying those at risk, especially when nutrition expertise resources may be limited and you need to target who may most benefit from intervention. However, unless I've missed a hot off the press article, at this stage there's no validated PICU specific nutrition screening tools as per this nice systematic review published a couple of years ago. They have outlined that a PICU specific NST would obviously need to address the factors relevant to this setting and this patient cohort and to importantly be predictive of meaningful outcomes. In the meantime, I guess if time allows and resources allow, I know in our region, the dietitians, for example, might screen the files or the handovers or attend ward rounds to try and get an approximate idea of those that may benefit from them doing a bit more of an assessment and potentially intervene. And then if we move on to those children that receive an actual nutrition assessment, so as per the published guidelines, this is recommended on admission so that you can pick up early if there's special requirements that need to be taken into account to diagnose malnutrition, any other nutrition-related issues, and to take that into account with the nutrition care plan. At this stage, there's no biomarker or validated nutrition score available, hence why an overall comprehensive nutrition assessment is required instead. So we obviously need to talk about the metabolic response to stress if we're talking about nutrition care in the PICU, because this significantly informs what is appropriate nutrition provision. So we have all evolved, obviously, to have certain metabolic responses to significant illness, stress, injury in order to survive before the days where we could have been taken to a nearby critical care setting. And the metabolic changes that occur mean that we need to be really careful with not overfeeding. We are often focused on getting some nutrition in, assuming that is the best thing to do, but in actual fact, early on, it can actually be harmful to provide excess macronutrients which exceed metabolic demand. So I've included reference and acknowledgement to some great papers that really nicely outline the metabolic response to stress and in the context of nutrition management. And so we think about it in terms of the acute, stable, and recovery phase. So with the acute phase obviously being when vital organ support is required, being implemented, being escalated. Stable phase, pretty self-explanatory, when that support is stabilizing out, and the recovery phase when that has been weaned and things are moving in the right, in a positive direction. So when we think about those different phases of illness and what our nutrition support goals may be, and taking into account those metabolic changes and trying to get that fine balance between avoiding the harms of under and overfeeding during the acute phase, we would aim to commence enteral nutrition early unless there were contraindications, and to very gradually increase towards provision of 100% of estimated BMR. During the more stable phase, we're trying to limit the loss of lean body mass and avoid excess fat deposition, once again through trying to achieve a fine balance between avoiding under or overfeeding. And then during the recovery phase, continuing to aim to limit loss of lean body mass or too much excess fat deposition, but also to fuel recovery and rehabilitation and catch up. So if we look at those two main areas when we're thinking about what a nutrition prescription would be, so energy provision being a good starting point. So as per those diagrams earlier, and considering the metabolic response to stress, so energy requirements vary over the course of critical illness, and I've already mentioned about the importance of aiming to avoid under and overfeeding. Indirect calorimetry is therefore recommended as per the guidelines to get a better idea of what energy requirements may be. However, we know that there's limitations to the children that may be able to be used in, but also importantly, there might be centres that don't actually have a device or the expertise. So when indirect calorimetry can't be used, the guidelines recommend estimating energy requirements using the Schofield equation. And then when we consider protein provision, so there's been many studies conducted in this area of critical care nutrition in both the adult and the pediatric space. And at this stage, we still can't definitively say exactly what the optimal protein dose is, although 1.5 grams per kilo has been associated with improved outcomes. And as you can see here, there's some more studies underway to investigate this further and over time generate more evidence for more definitive targets for different age groups and stages of illness. So if we pull all of that together, what does that mean in terms of our energy and protein prescription? So thinking about it in terms of the acute, stable and recovery phase, for energy with our nutrition prescription in those early phases, we're aiming to start early, aiming to match resting energy expenditure and gradually increase if tolerated. But then as you can see during the recovery phase, some children may need at least double that amount to fuel their recovery. Anthropometric and biochemical measures can help with guiding that. And then with protein in the acute and stable phases, starting at about 1 to 2 grams per kilo, increasing that. And this once again will be guided by the different age groups. And then also there might be other considerations, such as if the child has renal impairment, so things would be tailored to the individual, hence the importance of individual nutrition assessment and prescription. So if we move on to the other components of nutrition, so micronutrients, I'm every now and then asked by team members in my unit if we need to provide any additional supplementation, or they might have mentioned some particular vitamin or mineral. So as per these great papers I've got noted here, at this stage they've summarised, and there's currently nil evidence for additional supplementation. If biochemical levels have been tested, we need to be careful with interpreting them, especially in the setting of inflammation. So what this all means at the moment is we aim to meet standard requirements. If a child's on enteral nutrition and receiving a complete formula, so a nutritionally complete formula that has micronutrients, then this is generally adequate. But if the child is on enteral nutrition for a prolonged period of time, or if they're fluid restricted and so not receiving a significant volume of feed, or if they're on a special modified nutrition plan which may not be complete, it's good to conduct an analysis just to be sure there's no particular nutrients that are particularly low. Oral nutrition, so always good to remember that not all of our kids in PICU are nourished via enteral or parenteral nutrition. So if and when oral nutrition is possible, ideally trying to ensure adequate options are available. That oral nutrition support may also, depending on the volumes that are taken, it may help to reduce reliance on EN. So by that, I mean specialized drinks or fortifying foods with fats and protein for extra energy and protein, obviously. And then also, of course, ideally facilitating breastfeeding and expressing for mothers who choose to do so. And there's some really nice work out of the UK here that I've referenced looking at the experiences of breastfeeding mothers with sick children in the hospital setting. Enteral nutrition, this is certainly an area you could more than easily provide a whole talk on. So when we think about what are the main considerations, so I've already mentioned, as outlined in the guidelines, it's recommended that ENs commenced early unless contraindicated. In terms of the route, there's no evidence to suggest that it should be anything other than gastric for most patients, unless I guess they're at high risk of delayed gastric emptying or significantly high aspiration risk, and then post-pyloric feeding may be considered. Administration, I liked this paper that I only just came across recently, which nicely defines or provides some definitions for the different types of administration. There's limited evidence to guide to say one's preferable over the other. It essentially comes down to individual patient factors and resources. So for example, nursing resources, if they're at the bedside and doing the administration. The what to feed, this is my area of interest for research. So it's generally, I think the consensus is express breast milk or infant formula for the little ones, or an age-appropriate complete formula. And then there's, as we all know, there's a range of options when we have therapeutic diet requirements, such as if the child needs to be on a ketogenic diet or have modifications for renal impairment, for example. And then also when considering enteral nutrition, the consensus is to avoid routine gastric residual volume monitoring unless there are good reasons or indications to do so. And the big gastric PICU trials underway in the UK at the moment that will provide us with some more evidence for this area. Parenteral nutrition, so if there's only some trials that you're going to be aware of in the area of pediatric critical care nutrition, the PEPANIC trial would certainly be one of those. I know in my journey working in the PICU, sometimes you talk to someone or hear someone have incorrectly just read the headlines or heard the odd thing and thought that it meant that PN in the PICU is bad and to avoid entirely. And we know that is not the case, but instead avoiding supplemental nutrition, supplemental PN in the first week is not recommended as per this trial, because it was demonstrated to result in more harm than potential benefit. So it therefore remains valid, though, that not in the first very early stages in the acute phase, but otherwise the usual indications for PN apply. And these are two good references to provide some more information and guidance in practice around that. And then just briefly considering the more the tailoring of nutrition to critical care specific interventions, so ECMO and continuous renal replacement therapy. So I've got some nice papers here for you to refer to in more detail from relatively recently to provide some more guidance in these areas. So for ECMO, some main takeaways are that early EN is recommended when the child is stable, and to cautiously upgrade this as able. And then with renal replacement therapy, when we're thinking about the nutrition prescription for these individuals, some of the key factors that will inform what's appropriate nutrition is the potassium, so whether that needs to be limited or not, certainly the fluid allowance, how much room you've got to work with, whether that's oral, enteral, or parenteral nutrition, and then also trying to consider dialysate losses as well. So as I've hopefully highlighted, and if you're not already familiar with those papers, reading through them more, you'll see that there's limited, although increasing evidence to inform our current guidelines, though there's increasing research with time, which is great to see. So if just to finish up looking at what are the current nutrition research priorities and emerging areas, because these are what you're probably going to see start to inform updated versions of the guidelines in years to come. So there's this great work from the UK published back in March 2022, which involved consumer stakeholders in setting PICU nutrition research priorities. So you can see there's a really nice range of priorities that are there that these are clearly the things that consumers and along with us clinicians think about. And then also just to finish up too, thinking about reflecting on what are the current nutrition research developments. If we look at the publications, the emerging areas, so this includes some technology, so skeletal muscle ultrasound, combined nutrition and mobility interventions, the role of the microbiome and pre and probiotics. So do we choose an EN with or without fiber, for example, and the role of nutrition in longer term outcomes. So in summary, nutrition should be considered in the daily PICU goal setting, ideally establishing and maintaining a multidisciplinary approach, and local guidelines for nutrition provision at your centre is recommended, and to consider the phase of critical illness for appropriate nutrition prescription. Thank you. And I hope to see as many of you as possible in Melbourne, my hometown, in 2026 for the next World Congress. Thank you.
Thank you so much, Jacinta. It's a great, for such a big topic, an amazing overview. Thank you. Very good question from Georgie, considering what you ended on. She's asked, you mentioned nutrition altered depending on the anthropological measures, medical factors like kidney function, etc. Is there a consideration to intensity of physical rehab alongside discussion with the physios on how to individualize this for patients to optimize their ability to get maximal gains from rehab?
Yes, definitely. I think working closely with the physio, and then also, sorry, I'm just reading the question you mentioned as well. I think there's a combination of looking what, say, the weight trends. So if the weight's going down, we know we're not providing enough nutrition. The child's satiety, I guess we also sometimes see once they're improving that they might start to get hungrier, and if they're asking for more, then to certainly try and provide more. In terms of more evidence around this, I think in the US I can't remember the name of the trial, but I think they're at the moment doing some research looking at the combined mobility and nutrition interventions, because it certainly makes sense that you need to have fuel to make the most of your recovery.
Thank you. And I was just going to ask as well, feeds get turned off for random interventions. I mean, I know physio is another one. Some physios turn off feeds for airway clearance if they're worried, turning off various procedures. Is there any sort of standardization around that now?
I don't think so. I think different units do different things, and I guess it is important and it makes sense to turn it off if the child's, like, I know there's times you don't want them to vomit after if you've got them on the tilt table or something like that. So it's probably not a good idea to fill them up with EN. This is, I think, where it's important for the nutrition prescription to take into account breaks. So not just having a 24-hour rate target, but also to have the 24-hour volume so that can allow for the breaks, and also to allow for catch up as required based on procedures and rehab, and wanting to be disconnected if they're at the stage where they can go off the ward to get some sunlight and that kind of thing.
Thank you. Any other questions for Jacinta, just pop them in the chat and we can cover those at the end. Thank you so much. That's great. On to our next speaker. Adriano has now joined us. Wonderful. Thank you so much. Adriano Conrado Rodrigues is an occupational therapist from Brazil, and he's going to be presenting his talk that he gave at Cancun on physical and occupational therapy utilization in the pediatric intensive care unit. Thank you so much, Adriano, and hopefully if you can share your slides with us.
Hello, thank you for the invitation and our organization also, Sarah. I'm an occupational therapist, so I bring research that is the management of orthosis for critical care newborn babies. I did a presentation in the Congress, and I received a lot of emails, people liking to know more about this team. But we have low publications about the use of orthosis in newborn and also in critical care and unit critical care. And so maybe this is why this points that I presented there was so relevant for the contest. So I like it so much, the feedback from the professionals there. So it's a pleasure to be here. And I was thinking to bring more like a web workshop for you. So I did a movie, and I will make an introduction, and then you can also make some questions if you like, and stop me because I talk too much. So let's go. In occupational therapy, we have this research that the orthosis, it's a kind of normal for adults and also for pediatrics, but not usual for newborns. And once I have this experience and intensive unit care. And once I saw in the hospital that I was working, that's a reference for hospital for newborns in critical care. Then we start to use orthosis together with the team, the multi-professional team, to try to prevent deformities and also to improve the function of the babies once they come from pregnancy, okay? And we saw that the results was so good in terms of development, and I have enough cases to make a publication, but it's I'm running a lot now, and it's my project for 2025. Maybe for the next Congress, we're gonna have some publication from my case. So we need evidence from these research and also from orthosis for newborns, okay? But in the video, we're gonna see that we have good results, and also we improve development and with less surgeries during during baby stay at the hospital once they were receiving other kind of treatments together. So let's go to bring the video, and then I can talk a little more. When I talk about diagnosis, we have the clinical, functional, and occupational diagnosis. So orthosis comes from the occupational diagnosis with some kind of functional vision, okay? And when we think about occupational diagnosis, we are thinking about the purpose of the research, like orthosis, and also the purpose of the movement that we're gonna improve, or the posture that are gonna keep improving the development of the child. So we have a connection here with the use of the orthosis from functional diagnosis and occupational diagnosis according with the clinical diagnosis. So we need to consider that. And in pediatrics, the development comes from play, okay? So we can think about a better movement or a better posture to functional play or symbolic play, and what we have the intention when we introduce an orthosis in the treatment of a child. We have special material for this orthosis, so we can bring some special polymeros. Is a kind of plastic, thermoplastic, that we make the orthosis. You're gonna see in the video, they're gonna be clear. And okay, we can use another kind of materials, but we have the specific one that are gonna be good for the skin of the newborn. So we need to see for that. And when we have the evaluation of the child, we are looking for the function, for the anatomic structure, for the physiological parts, and then we can find the right orthosis for our newborn. If we consider like the routine for use the orthosis, usually I give some orientation for the team, like 2 hours using the orthosis and 2 hours without orthosis, because the joint needs some movement also. And we can make this changes like routing with the oxygen sensor. So when the child is using the oxygen sensor in one hand, we can apply the orthosis in the other hand, and also with the foot. And what I got was like 2 weeks using the orthosis in this routine. We can see some good results. But as I told you, we don't have any evidence about these protocols, you know. So maybe it's a project to develop together.
Adriano, just out of interest, you do those we would call them splints in Australia. I think that's what we're referring to. Do you put them on what's the youngest that you would use the splints those on?
Yeah, I had a child in the hospital, premature newborn, like 26 weeks. It's pretty little, and the baby was stable, but it's not a condition, you know. You can bring the team together, and in that case, that was the newest that I put the orthosis was 26 weeks. But you can study the case with the team, and once you see that we're gonna be good for the baby, you can bring the best position. The principal thing, the main important thing is that once you make a late approach, maybe it's gonna not be so easy to prevent a deformity, or also to bring a better posture for the baby to development. So as early as possible, I think it's gonna be a good thing. And that's the point. It's a good question, Sarah. That's the point that maybe are gonna be the objective of our research there.
Can I ask what was the interest, the questions that you had from in Cancun? What were most people's consideration to you?
Yeah, good. So in Cancun, people asking me about the material, about what I was using for orthosis to make the orthosis, and also about the biological procedures to keep all clean. That's an important thing in the hospital. It was the most critical points. In the hospital, I usually make the orthosis in the orthopedic room, that they are already organized to access the unit care, and also with all biological security. And it was working for me and works for me, and it's an advice. Careful with the material and the procedures that you make, because it's very critical, as you all know. And about the materials, we have some good materials coming from United States. What I like most there is the brand Easy Form. I can send you the comments. Easy Form is a brand that's maybe the most Everyone likes easy form, and in China they are very close from the quality of easy form with another materials there, but the price is not still not competitive. Coming here in Brazil, in the United States, easy form is the more that the professionals use more there. You have some advice about the use of the material that we need to consider, that the skin of the newborn that's so thin, and if you have pressure you can damage, so you need to be careful as a professional. And also, if you have the team together, you can make the right orientation. In the hospital that I work, I have the parents of the child together. It's a humanity unity. So the parents stay together with the child all the time. So I have the parents together to take care and monitoring all the orientations.
Thank you, Adrian. That's actually a very good segue onto, because we're now at that's the at 6:40. That's a perfect segue onto the family, which is our next speaker will be Susan. So thank you, Adriana. If anyone's got any further questions for Adriana, put them in the chat. I do think what you discussed may be something that we should consider at WFPICCS in Melbourne. If we're looking at splinting and different materials, maybe it's something that can be added for discussion at the next conference, as it raised so much in Cancun. Thank you so much, Adriana.
Also more evidence. Thank you.
We'll hand over now to Susan Khanna, who is a social worker from Australia, who's going to talk on working with families to ensure best interest of the child. Thank you so much. Over to Susan.
So thank you for the opportunity to present the talk that I did at WFPICCS in June. The topic that I was asked to talk on was working with families to ensure best interest of the child. And I thought to present a recent case that my entire team was very heavily involved in, and as being part of a team for a very long time. The allied health, the medical, nursing members of the team worked incredibly hard with this family, and I thought there's no better way to describe it than actually go through a case presentation. So hopefully this is of interest, and you can relate to maybe another family that you have worked with over your time. So I'll just, Okay, I first wanted to start with acknowledging Dr. Andy Christoph, who's the medical director of the PICU at the Children's Hospital Westmead, Sydney Children's Hospitals Network in Sydney, Australia. So Dr. Christoph has provided the medical component of this presentation and the child's condition just for my benefit. So as a social worker, I wanted to make sure I did bring forward the child's medical condition and the complexity to the best way that I can. It's not moving. Okay. So this is a case of a 3-year-old female who's a DCD8 twin, who's previously well. There's no prior hospital admissions, no allergies, no medications. The social component is that the parents were from South of Asia and they spoke 3 languages, their native language, English as well as Hindi. Now, Mum's preference was to speak in Hindi with me when she was on her own, as we know that in times of distress for families, they often want to revert to the language that they feel most comfortable communicating in. For this family who were quite isolated in a way because all of their family were overseas, but luckily for them, the maternal grandmother was visiting from overseas, and they had no other family locally, but a small network of friends from their local community. So she first presented to the emergency department on the 21st of November, 2023. She'd been unwell for 6 weeks. She had a rash to her face, feet, and elbows. She hadn't been playing as much, so parents noticed that she was quite fatigued. She didn't have any fever. They hadn't been traveling recently. She'd lost a bit of weight as well. So they were admitted under general medicine and reviewed by dermatology and rheumatology and discharged after 72 hours. So 7th of December, they presented again to hospital, this time with fever and cough, and she had increased work of breathing. They did a lot of blood tests at the time and commenced her on IV antibiotics, and she also required low-flow nasal prong oxygen. So she had 3 days of steroids, after which there was a little bit of initial improvement, but gradually her need for increased support was quite evident. So day 4, she showed signs of progressive tachypnea, and she was moved from the ward to the PICU. On day 7, she required intubation. As you know, her condition progressed very rapidly. Day 13, she had a working diagnosis of PJP pneumonia. On day 14, the chest X-rays showed extensive lung damage, and by day 15, she was placed on WFPICCS24. So these were some of the tests that she had done that included infections for lots of different conditions, as you can see there. CMV, mycoplasma pneumonia, malaria, Q fever. There was concern around TB because the maternal grandmother had been living with them for about 9 months prior to this illness. There were no malignant cells found. She had genetic testing. However, when she had her lung biopsy, it showed significant fibrosis. So 6 weeks into that admission from PICU, she remained on WFPICCS and showed signs of air hunger. So the MDT impression at the time was that this was end-stage lung fibrosis and a condition that she wouldn't be able to recover from. So at this time, the parents were, residing in the hospital. So the father at the time of admission had stopped working, completely took some leave, but, he'd exhausted all of his leave. The mum was working casually, so she had no income coming. They had, as I mentioned before, they had really limited support network. And, there's a lot of concern for the twin sibling who was at home with the maternal grandmother. So parents stayed in the hospital because they couldn't bear to be away from, their daughter, whose condition was quite uncertain, and she was quite acutely unwell. They would be quite visibly distressed at the bedside. There were days when they would hardly speak, and outside of the MDT meetings, particularly Dad, there was very minimal communication. They were very present, very hands-on with her. In my conversation with Mum, she'd often talk about the first presentation in the emergency department, and there's a lot of concern, a lot of questions in her mind, in both their minds, about whether something could have been done at the time in the emergency department that could have prevented her from becoming so unwell. As we know, grief plays out in different ways for different families, but the impact of a prolonged admission with ongoing stress and no end in sight can be quite, quite difficult for families and very isolating. And it was quite noticeable that, the family were just absolutely in shock. And Mum would say to me, she didn't have cancer, I can't accept this. And she had been so well prior to this illness, if there was something I could accept, I would handle that much better. But, so a lot of time spent at the bedside. There were days when the dad would talk a lot more than Mum, but they had their own range of emotions that they were experiencing. There were mental health concerns for mum. So the twins were born during COVID and she was isolated from her family. She, couldn't have her mother at the time to help with the birth. And she often spoke about the death of her father during COVID and not being able to go overseas to be with him. Psychiatry were involved to manage symptoms that the little girl had, and we offered their support to mum because we were really concerned for her mental health as well as for dad, but we thought we would, encourage her to talk to someone outside of me if, that would be of help. And she maintained that she was okay and she was okay to have social work input, but didn't feel she needed further input. So the key considerations for our team, obviously parents wanted to make sure that everything that could be done was done for their little girl. There was a lot of challenge for us in trying to manage, maintain trust and manage the partnership with lots of different teams that were involved, from respiratory, infectious diseases, immunology, genetics, pain, cardiothoracic, just to name a few. And we wanted to make sure all teams were collaborating and communicating with us, and we communicated with the family as a team rather than individual subspecialty, which often can be quite confusing for families in PICU, as we know. The parents had a paternal aunt who, so dad's sister was a physician overseas, and so early on in the admission, we could identify that she was quite a significant source of support for them, and also someone who helped them understand the medical challenges for the patient. So we included her in every MDT. We sent her reports, which is what she wanted. Parents often would talk, and they mentioned this to me a couple of times. I mentioned it in one of the MDTs as well, that they felt that maybe because they were from overseas and they, had the ethnicity, that whether their doctors back in their home country would have better knowledge of this rare condition that their daughter was dealing with. So they, often referred to that as being something that they wanted to explore. One of the other considerations for our team was looking after this little girl who was awake and engaging, and it was something that impacted on all of us, particularly the nursing staff and the allied health team that were, so we had child life therapy and our physiotherapy team that were very actively involved in her care. And so there was particular care that needed to be taken because she was a patient who was awake. And just to give you an example, when they did suctions for her, often they were sort of blood stained. And so our team were quite involved in making sure that she didn't see or, there was minimal trauma for her during the personal cares. There's a lot of time that went into the planning of the MDTs. We had regular MDTs weekly, but sometimes it was twice a week as well. But normally we don't always have the luxury of, having enough time to pre-plan a meeting and think about how we're going to present the information, who's going to be contributing what, and, making sure that it was a collaborative effort. So a lot of time was spent in planning of the meetings, and then often after the meeting also reflecting on how that went and preparing for the steps ahead and what needed to happen next. The risk versus benefit question was in everybody's mind in terms of, the prolonged period on ECMO and where were we heading, where were we going to land with the care of this patient. So how we tried to ensure best interest in this, in this case is that we had a primary care MDT team, which included one primary intensivist. We had one main representative from each of the clinical teams, and they were involved in pretty much most of the meetings. If they couldn't attend in person, they were present virtually, just to ensure consistency in the communication. We made sure the meetings were at a time that the paternal aunt could log in from overseas, and she often joined in on video calls. There was opportunity for her to talk to the MDT team after the meeting as well if she had particular questions, because we saw her as a key figure in helping the family to adjust to what was going on. The second opinion was raised by us, so we offered that to help the family, accept that perhaps this was an irreversible situation. So opinion was sought from overseas as well as locally, and the case was also presented at a local meet, which is a meeting of all the respiratory physicians from actually Australia, New Zealand, and the case was presented at their meeting. So the lung transplant referral was made. Initially, she was not considered as a candidate. So as per Australian guidelines, under 20 kilos of weight and, less than 5 years of age. Generally, someone is not considered to be a transplant candidate. However, we referred her to the Lung Transplant Centre, which is in Melbourne. And the reason for that was that given she had a single organ failure and, we wanted to make sure that no effort was spared with managing the child's care. So the transplant workup was initiated. We had meetings with the Melbourne team who flew in to see the patient and do their own assessment. And then, following the transplant workup, we actually had a diagnosis. So the myositis screen, which is an important workup for the transplant, showed an increase in MDA5 autoantibodies, and a diagnosis of juvenile dermatomyositis was made. Sorry, just stop moving there. So juvenile dermatomyositis is a rare condition. It's rare in adults and extremely rare in children. It associates with aggressive lung disease, which is rapidly progressive in nature and has a very high mortality. There's also a very high risk of recurrence in transplants. So this unfortunately excluded her from being a candidate for transplant. So the outcome of that meeting was that we had an MDT with the family again, where we shared the diagnosis. And I still remember from that meeting, there was a very big difference in the acceptance of the diagnosis from mum and from dad. So mum at that point, in the initial phase, was more wanting to do everything that, could be done. And she said to me, even if she's disabled, if she can't do anything for herself, I want my child to be alive. Whereas dad used to be very quiet at that time. When we shared the diagnosis, the mum went really quiet and hardly spoke, during the meeting, whereas the father had lots of questions about what could be done. Okay, why can't she be a candidate? Have we consulted everyone overseas? Are we sure about this? So while we were waiting for the final decision, we started her on treatment to reduce the MDA5. So this whole the last few days happened within a week. So she had some time to try the treatment to reduce the autoantibodies to see if that was effective. And then a final decision came back from the lung transplant center that she would not be a candidate for transplant. We had another MDT then. This time again, we had the aunt joining in virtually, and the primary PICU team and the transplant team were virtual at this point, and they explained the reasoning. And, you know, both parents to our, you know, it was something that we didn't know how that was going to go. So we had our psych team on standby. I was really concerned that mum was going to have a very strong reaction and that we might need to support her and make sure she was safe. So we had them waiting in a separate room to where we were meeting. And the parents were just, you know, quite accepting and very quiet. And we focused on redirecting her care, and we talked about memory making in this meeting. So the parents were devastated, as you can imagine, but accepting of the, you know, irreversibility of the situation. And we tried to focus on memory making. During this period, the twin sister had COVID. And so that presented as a challenge in terms of being present in the PICU space. So we organized for them to all stay in hospital in a section of the ICU. Closed observation unit was blocked for the use of the family. And we had the parents staying with the patient and the twin sibling also staying with them. The room was decorated amazingly by our nursing care team. We explored what, you know, the little girl would have liked, and the parents said she loved pink and she wanted, she loved her Barbies and she loved the princess outfits and the jewelry. And we have amazing, again, the efforts of the MDT team. The room was decorated with the Barbie theme. Staff wore pink, and she was dressed in her favorite princess party outfit. Parents, when she asked, you know, could she go home? And they said, well, she was getting ready for a princess party and to go home. She asked for lollipop and chocolate milk, and we gave her all of those, everything that she asked for. We had the Hindu priest who was, you know, there for the family, and prayers were said during the decannulation from ECMO. They were supported by family and friends who joined virtually from overseas. And it was a very sad moment for our entire team, and it impacted on a lot of our staff at the time. But it also, I think it was one of those situations where we could say that we, you know, did the very best in a very, very difficult situation, a very sad situation, to support the family as a team. So just your thoughts and questions.
Does anyone have any questions for Susan?
I've got a really quick question, Sarah, if that's okay.
Okay.
Susan, you said that a lot of time and planning and teamwork went into this, and it went on for a long period of time caring for this little girl. Just the impact that potentially has for the other patients in the unit, when so much time and coordination is happening for one patient. Do you feel like things change for the other patient or is there more of a focus on equality at that point?
I think, it's always a challenge for us because the ICU is a space where a lot of things happen, unfortunately, for parents. They're often witnessing trauma that other families experience as well. And we know, and that's well documented, about the impact of what the parents see in ICU that's not related to their own child. In this case, yes, there was, it did cross the team's mind that there were a lot of other patients as well in the unit. And so I think having a primary care team helped manage that to an extent so that the other patients that needed that level of input had care and team assigned to it. It's not always ideal, but I think we tried to minimize the impact on staff, which was quite big at the time. Like I said, it was for all members of the team, including, people that assist on the ward, our admin staff, because people become quite invested, as you know, and attached to families. So I'm not sure that we did our very best when it came to, supporting staff, and perhaps more could have been done, but debriefs were organized. There's also bedside debriefs for nursing staff were done by senior nursing colleagues. But I think, yeah, it is a question of how we divide our time the best way that we can when these situations do occur. I don't know if I've answered your question, Kate.
Yes, thank you.
And you've actually answered partly Kate's question in the chat. Do you facilitate debriefing for staff after the event like this?
Yeah, we do. However, in this case, I chose not to because I was also one of the team members that was impacted by this situation. So I do co-facilitate with one of the, senior members of management, either a medical, staff member or nursing management. So usually the debriefs are more, it's around peer support and a chance for people to reflect on the impact of the work. However, in this case, I was impacted myself. So I organized it with our psychiatry team, and we had couple of the staff members from our psychiatry department actually come in and run this for us as an outside, perspective, to allow me a chance to do what I needed to do for myself and as a member of the team.
Thank you. Anybody else have any questions there? I think that case probably resonates with all of us. And I think that's why you did it as a case, because we all can have elements through all our careers where we fought a challenge of this situation, and everyone's unique, but they all have similarities in some way. And I have to say that your own vulnerability is recognized too. It's often hard to sometimes show that. So thank you very much for that presentation. If there's no other questions, I think that's all great. Thank you to all three of our speakers today, to Jacinta, to Adriana, and to Susan. Thank you for presenting. I know all of the allied health representation at Cancun was significant, and that's why we've been running these events, so the rest of the world can actually appreciate what you spoke about too, and obviously get momentum going for next year's event. Just to highlight that the next session will be next Tuesday, the 12th of November. That's 8 p.m. Brisbane time, 9 p.m. Sydney, Melbourne, and 10 plus 10, so 10 hours on from Greenwich Mean Time. So hopefully, please invite as many people along to that to join. And obviously, this will also be available as a recording. So thank you one and all, and take care.